Good morning, and welcome to the January COPE webinar entitled PCOS and Weight Management, Best Strategies for Healthcare Providers. PDFs of today's PowerPoints are posted on the COPE website at villanova.edu/COPE. If you are experiencing any technical difficulties, please use the chat feature at the right of your screen to state your problem. The chat feature will also be used for questions and answers. All questions will be answered at the end of the program. We will leave 10 minutes for questions. The expected length of the webinar is 45 minutes. The session will be recorded and placed on the COPE website within the next few days. My name is Denise Furco-Adams. I am a registered dietitian and the director for the McDonald Center for Obesity Prevention and Education at Villanova's College of Nursing. A nonprofit center, this is a monthly series of professional webinars provided by COPE. Villanova is the first college of nursing in the country to have a center devoted to obesity prevention and education. As this slide illustrates, COPE goals are to provide continuing education programs like these webinars, partner with other agencies and organizations focused on obesity prevention and education, participate in research, and enhance education of students, professionals, and the community. Today's speaker is Angela Grassi. She is the author of the PCOS chapter in the Academy of Nutrition and Dietetics Nutrition Care Manual and the author of the Dietitian Guides to Polycystic Ovarian Syndrome and the PCOS Workbook, your guide to complete physical and emotional health. A past recipient of the Award for Excellence in Graduate Research from the Academy of Nutrition and Dietetics, Angela is the founder of the PCOS Nutrition Center, where she provides nutrition counseling to women all over the globe with PCOS. She is also an adjunct professor at Westchester University of Pennsylvania. Having PCOS herself, Angela has been dedicated to advocacy, education, and research of this syndrome. In today's webinar, the learner will be able to recognize the pathophysiology of PCOS, identify two medical conditions for women and PCOS, recognize three medical nutrition therapy guidelines of polycystic ovarian syndrome, and identify two effective nutritional supplements that are used. The webinar is approved for one CPEU awarded by the CDR, ANCC, and ACSM. The CDR learning code is 4180 and the activity level is 2, and the presenter has no disclosures to make for this presentation. Before we begin the presentation, we'll be doing a short poll. And that polling question will be appearing shortly. So please indicate if you are an RD, an RN, or some other type of health professional, or if you are a woman with PCOS. If you are using a tablet, you may not be able to participate in the poll. And as I can see from the poll, 81% are dietitians, 7% are nurses, 6% are other health professionals, and 6% are women with PCOS. The second question is, please indicate if you're a health professional, what type of setting you are in. Private practice, clinical, community, or other. And with 80% of responses, we have 25% are in private practice, 40% in clinical, 12% in community, and 25% in other. At this point, I will be turning over the presentation to Angela. And Angela, where is she? I'm sorry, Angela. I had you muted there, so now you have the microphone. So,
thank you. Well, welcome everyone. Welcome to PCOS and Weight Management Best Strategies for Healthcare Providers. I'm Angela Grassi, and I wanted to thank Villanova University College of Nursing for hosting this webinar today, and to Denise Burko-Adams for inviting me. This is a topic that is near and dear to my heart. As Denise mentioned, I do have PCOS, and like many women out there, some of yourselves perhaps that have PCOS, I was misdiagnosed even after going to numerous doctors, even suggesting that I had this condition. And unfortunately, the doctors and health professionals I encountered just didn't have enough knowledge about this disease. So I'm always very appreciative anytime I have the opportunity to educate others about PCOS. So today we're going to talk about PCOS, to discuss the pathophysiology, associated signs and symptoms, the associated health risks. We'll talk about how PCOS changes with age, treatment options available to women with this disease. We'll talk about medical nutrition therapy techniques, as well as popular dietary supplements that may be effective in improving PCOS. And we'll spend some time talking about practical applications and some strategies that you can use in your work. PCOS is the most common endocrine disorder among women of childbearing age. It affects 6 to 10% of women in the United States. It's a highly underdiagnosed and undertreated disease, and part of that reason is because PCOS is multifactorial, it's polygenic, and it has variable phenotypes. So just last month, in December 2012, I attended the NIH workshop on PCOS, and this was a 2-day workshop that presented the most evidence-based information on PCOS. And what they were saying was that there are at least 10 different phenotypes associated with PCOS. So for instance, a woman can be lean with PCOS but have high androgens, or she can be obese with PCOS and have high insulin and be in ovulatory. Another woman could have obesity and be ovulatory. So there's at least 10 different phenotypes associated with PCOS, and what came out of this NIH workshop was that they recommended that when researchers start to conduct studies now on PCOS, that they specify which phenotype they are doing the study on, what kind of type of woman with PCOS, so that we can learn more about what therapies are going to be effective for different phenotypes of PCOS. So the diagnostic criteria for PCOS, this was something else that was brought up at the NIH workshop, was do we keep this criteria, which is also called the Rotterdam criteria, or do we use a different criteria for diagnosing PCOS? And it did come out that it was agreed to keep this diagnostic criteria, which basically says that to diagnose PCOS, you must have 2 of the following 3 criteria. The first is oleo or anovulation. So basically 8 or fewer menstrual cycles in a year. Now I do want to mention that you can have regular menstrual cycles and still have PCOS. The second criteria is having clinical and or biochemical signs of hyperandrogenism. So basically having the blood tests that indicate high androgens, whether it's a total or free testosterone, looking at clinical signs, does a woman have the acne, the extra hair growth, also called hirsutism, or does she have alopecia, which is the hair loss associated with the high androgens. And then the third criteria could be, does she have the presence of the polycystic ovaries on an ultrasound, which classically looks like a necklace or a string of pearls. Now not every woman with PCOS do have cysts upon an ultrasound, And I do want to mention that some women can have cysts and not have PCOS. So it just makes, it's a very complex disorder, and that's why it was brought up at the NIH workshop. Is there a better criteria we can use? But right now this is the one that is sticking, and it's certainly PCOS is a condition of exclusion. So you must rule out any other conditions that might be causing any of the other criteria mentioned here. So PCOS is a reproductive disorder. Certainly women have oleo or amenorrhea, higher risk of infertility. In fact, PCOS is the leading cause of ovulatory infertility. Pregnancy loss is common, preterm and stillbirths. The presence of the cysts and endometrial cancer is also more prevalent in PCOS because of the amenorrhea and the failure to shed the uterine lining. But we also know that there's many metabolic risk factors associated with PCOS. For instance, around 50% of women with PCOS have hypertension, 50 to 70% have abnormal glucose metabolism. 70% have dyslipidemia, classically that high triglycerides and low HDL that's associated with insulin resistance. 40 to 80% have obesity, and 50 to 70% have insulin resistance. So compared to weight-matched controls, women with PCOS do have an elevated prevalence of metabolic syndrome. They have a higher prevalence of hyperinsulinemia, or high blood levels of insulin. They have a 2.5-fold prevalence of impaired glucose tolerance and a 4-fold prevalence of type 2 diabetes. So we do know that PCOS is an independent risk factor for type 2 diabetes, and we do know that independently of BMI, so meaning you could have an obese woman or a thin woman with PCOS, they're typically going to have higher insulin levels than those of the same BMI. What we're also seeing in PCOS is a rapid conversion from having impaired glucose tolerance to type 2 diabetes. So it seems like as if when a woman does have impaired glucose tolerance, within a year or two, she gets full-blown type 2 diabetes. For that reason, the Androgen Excess and PCOS Society recommend that if a woman has a normal glucose level, that she be screened with a 2-hour oral glucose tolerance test every 2 years. If she has other risk factors, or if she does have impaired glucose tolerance, that she be screened annually with an oral glucose tolerance test. Other diseases associated with PCOS include hypothyroidism and autoimmune disorders. Obstructive sleep apnea is highly prevalent in the PCOS population. One author suggested it's as high as 30 times higher in women with PCOS. The reason is not just because the majority of women with PCOS may have obesity or be overweight, but more related to the androgen levels, that especially testosterone can actually affect the sleep receptors in the brain, resulting in sleep apnea. And we also know that when you have sleep apnea, it does worsen the insulin resistance. So treatment with the CPAP machine, which is typically recommended for obstructive sleep apnea, does help to improve insulin resistance in PCOS. So I think we, as healthcare professionals, we really need to be screening for obstructive sleep apnea, asking them if they are snoring or if they stop breathing, if anyone has ever told them that they did that in their sleep. Eating disorders is very common as well in PCOS. There's a lot of dermatological concerns that women with PCOS have, whether it's acne or significant hair growth or hair loss, and the rapid weight gain that a lot of women with PCOS experience can all affect their body image. You also have the insulin component, which we're going to talk about today, which can lead to low blood sugar, can lead to triggers to overeat or to binge eat. Non-alcoholic fatty liver disease, or NASH, are also common in PCOS. Mood disorders, we see higher rates of anxiety, depression, bipolar, and higher rates of suicide in PCOS compared to women without the syndrome. Certainly higher risk of coronary artery disease, and we're also seeing not only higher rates of gestational diabetes and pregnancy in women with PCOS, but higher rates of preeclampsia. So I'm going to walk you through this pathophysiology of PCOS, which looks like a tangled spider web. Here in the middle we see androstenedione, try saying that 10 times in a row, and testosterone. So in PCOS, there are increased ovarian production of androgens, so those androstenedione and testosterone. So the increased androgens may be due to insulin. So there's insulin receptors here on the thecal cells of the uterus, right here in the middle. Increased insulin stimulates those thecal cells to increase androgen production. So on the other hand, the increased androgens may be the result of increased gonadotrophin-releasing hormone pulsatility. So up here on the top right, rapid high-amplitude pulses can actually increase luteinizing hormone secretion. And then elevated luteinizing hormone stimulates the androgen production from the thecal cells. Now, although we know that hyperinsulinemia results from insulin resistance, we do not know why gonadotrophin-releasing hormone has increased pulsatility in women with PCOS, which favors the increase in luteinizing hormone. Now, to complicate matters, insulin significantly amplifies the luteinizing hormone responses to gonadotrophin-releasing hormone. And then on top of all that, insulin down here on the bottom left causes reduced levels of sex hormone binding globulin. Now, sex hormone binding globulin binds to testosterone. So when you have low levels of it, it'll cause an increase in free testosterone and inhibit follicles and inhibit basically ovulation. So it's a very complex syndrome. And as we talked about, insulin is kind of the trigger of a lot of it. So here we have the high insulinemia, high blood levels of insulin, and insulin is a growth hormone. It's a potent growth hormone that promotes weight gain or fat storage very efficiently. And that's why a lot of women with PCOS tend to gain weight, and sometimes the weight can be very rapid and uncontrollable. A lot of times a classic sign of it is the extra weight above the belly button, or an extra, one woman calls it like a spare tire around her middle, a patient of mine. And you can also tell on the skin if a woman does have high insulin levels by looking at what's called acanthosis nigricans, which is Latin for dark skin. And a lot of women with PCOS, especially in darker skinned women, will have dirty looking patches, whether it's on their knuckles or behind their neck. A lot of times it's under their armpits, and that's actually a sign of hyperinsulinemia. So hyperinsulinemia has a direct effect on the ovaries to produce higher levels of androgens like testosterone, which will cause androgenic symptoms like acne, the anovulation resulting in infertility, and hirsutism, which is like extrafacial hair or hair on other parts of the body that can be problematic. And for some women, it's significant. It really affects their quality of life. I had one patient who I saw last month who got married a couple months ago, and the day before her wedding was actually hand plucking out every single one of the hairs on her face so she wouldn't have a dark shadow that she usually gets if she tries shaving it. So it has a significant impact on body image and quality of life. We also know that hyperinsulinemia can have a direct effect on the endothelium, causing endothelial dysfunction, resulting in that dyslipidemia, hypertension, and diabetes. So it's a vicious cycle that the more insulin a woman has, the more weight she tends to gain. The more weight she tends to gain, the more insulin resistant she becomes. And the cycle keeps going. Now, adolescence is perhaps the most vulnerable and influential stage of PCOS, and it's right in adolescence when the symptoms of PCOS first start to present themselves. Typically, it could even just start with acne, which, what adolescent doesn't have acne at some point in her life? And one of the classic signs that you can check for with adolescents, because they might not have cysts yet, they might not even have irregular periods yet, is the high testosterone or high androgen levels. So it's really here in adolescence that changes can be made to diet and lifestyle that could prevent the worsening of symptoms later on in life and present the onset of many health complications. And what this image shows is how the natural history of PCOS progresses with age. In adolescents, they might first start to see some irregular menses or start to have signs of the hyperandrogenism. Going on to childbearing age, they're more likely to have diabetes or have dyslipidemia or high blood pressure or obesity. And then going on past menopause, the increased risk of cardiovascular disease, cancer. And what this slide is showing is we now have a lot of data, which is exciting. Just this past year, about 2 longitudinal studies have come out to show what happens to women with PCOS as they age. Now, PCOS has always been viewed as a reproductive disorder, so the research has mostly been done in women in their 20s and 30s or maybe a little younger, but certainly not older. So what we know is that women with PCOS do differ in reproductive hormone levels as they age, that androgen levels, yes, do eventually decrease, but still remain higher longer in women with PCOS. And believe it or not, women with PCOS might start to experience more regular menstrual cycles. They might have a better chance of conceiving as they get older because those androgens start to decrease. What we do see is that hirsutism may persist past menopause, and that could just be from chronic, lifelong exposure to the high androgen levels. And we also see a worsening of the metabolic parameters, the impaired glucose tolerance, insulin levels could worsen. So women with PCOS are at an increased risk for lifelong health issues well beyond menopause. Here are some frequently observed lab abnormalities. So typically you'll see an elevated total testosterone, an increased luteinizing hormone to follicle stimulating hormone ratio, DHEA sulfate, that's another androgen, the precursor to testosterone, and it is typically elevated. You'll see elevations in fasting glucose and insulin, TSH levels may be abnormal. You may see elevated C-reactive protein, high triglycerides, and that low classic low HDL in PCOS. So traditionally, if a woman had irregular menses, she would be put on birth control pills to regulate her periods. The birth control pills can also help with hirsutism, that extra hair growth, can help with acne and the alopecia. There are some risks with the oral contraceptives in PCOS, and that includes that the oral contraceptives may increase triglycerides, which women with PCOS already tend to have higher levels of. It may also increase the risk of blood clots, which is commonly seen in PCOS, and may contribute to insulin resistance. We also see that Clomid has been an effective treatment for women who are experiencing infertility. We also know that anti-androgens are available to help with the hirsutism and alopecia and acne. Spironolactone, also known as aldactone, it's a very weak antihypertensive medicine that seems to help act as an anti-androgen. What we do know is that weight loss is 5% of total body weight is effective at improving both the metabolic and reproductive abnormalities we see in PCOS, that losing weight can help to resume an irregular menstrual cycle and help improve those metabolic aspects like the high triglycerides and that low HDL, and improve insulin resistance. Now, PCOS is really, because of all the other associated risk factors that you saw, it's really a multifactorial treatment approach that has to involve a healthy eating plan and supplements, which we'll talk about today. Physical activity is very beneficial in improving insulin and the metabolic risk factors associated with PCOS. Sleep hygiene, as I mentioned, obstructive sleep apnea is very common in PCOS. Stress management to combat that elevated cortisol level, which has a very powerful influence over insulin. And we do know that there are insulin sensitizing medications available for women with PCOS, most commonly metformin, and some of the newer GLP-1 receptor antagonists like Byetta or Victoza, which I'm seeing really good results with both of these in helping to improve that HA1C, that hemoglobin A1C, and insulin in PCOS, as well as weight loss, if you can get past the significant side effects that the injectables have for some. So metformin, again, is perhaps the most common insulin sensitizer in PCOS. We do know that if a woman is overweight, that metformin may help with her fertility. Because it's improving the insulin, it might help improve the testosterone, help to resume ovulation. Metformin also can help improve the endothelial function, reduce blood pressure, lipids, and glucose levels, and overall the risk for cardiovascular disease. Metformin, we always hear of the worst cases, but in general it is pretty well tolerated. The average dose is 1,500 to 2,000 milligrams. There is an extended release version available if a woman is having a hard time tolerating it. Metformin does cause malabsorption of B12, so it's very important that if a woman is taking metformin, especially at that high dose that I mentioned and for a prolonged period of time, that she really should be supplementing with a B12 supplement and have her levels checked annually. So it brings us to the million-dollar question, which is, what is the best eating plan for PCOS? Well, the optimal eating plan for PCOS is not yet determined. We really need, because of all the different variabilities with the phenotypes, we really need to individualize the eating plan. And that's why it's so important that women with PCOS meet with a registered dietitian to go through a detailed nutrition assessment for her PCOS to determine what's going to work best for her. It's also very important if insurance would cover women with PCOS to see a dietitian as they do for type 2 diabetes and type 1. So what we do know, there are some eating plans that have shown favorable effects on weight loss and metabolic parameters in PCOS. These could include modifying the glycemic index or the glycemic load, modifying the overall amount of carbohydrate, fat, or protein. Using meal replacements have been shown to be beneficial, at least in the short term, as well as structured meals. Long-term goals for medical nutrition therapy would include reducing body weight if a woman is overweight or obese, and to help them maintain that weight loss after their weight reduction, so to help them to have the knowledge and skills to support these behavior changes. Engaging in 30 minutes or more of moderate intensity activity most, if not all, days of the week. And thinking long-term to resolve the metabolic syndrome and reduce the risk factors for type 2 diabetes and cardiovascular disease. So the nutrition prescription could be a reduced energy diet, perhaps 500 to 1,000 calories below their total energy expenditure for weight loss, to reduce their intake of fats and carbohydrates to achieve that reduction in energy intake. But really for caloric intake to be distributed evenly throughout the day, perhaps 4 to 5 meals and snacks, making sure to start the day with breakfast. I see such a pattern of women who skip breakfast and they're hungry all day long. So it's important not only to have breakfast, but to have a good amount of protein or some fat there. It makes a big difference in stabilizing those blood sugar levels throughout the day. And that can help to prevent any cravings or low blood sugar. Portion control, very important, should be included as part of a comprehensive weight management program, showing women how many carbohydrates are in foods. For example, that a bagel has 60 grams of carbohydrates in it, that it's the equivalent of 4 pieces of bread. So education on portion sizes and reading food labels can be very effective. I want to bring your attention to this one study that was published this past year about the effects of increased protein and carbohydrate ratios in women with PCOS. So this was a controlled study. It involved 27 women with PCOS, and unfortunately a lot of these studies in women with PCOS are a limited sample size. But this was a 6-month trial, and women with PCOS were either following a high-protein diet involving 40% or more calories coming from protein and 30% fat versus a standard protein diet of 15% or less calories coming from protein and that same amount of fat. Now, there was no caloric restriction, so the women could eat whatever, as much as they wanted. They just had to try and increase their protein intake if they were following the high protein diet. They did receive dietary counseling. What they found was that the women who followed the high protein diet had significantly greater weight loss and significant body fat loss, reductions in waist circumference and reductions in glucose level. Now, they didn't see any difference as far as lipids and hormones, but they think the researchers speculated that just having all that protein really added to satiety. So it resulted in overall less food intake, and that resulted in the greater weight loss and body fat loss that we saw in this study. So protein definitely may make a difference in women with PCOS. I also want to call your attention to this other study that it looked at either a low glycemic index diet versus a conventional diet in women with PCOS, and this involved almost 100 women, and it was followed for a year. Women either, both the macronutrient contents were the same for these diets. They were 50% carbohydrates, 23% protein, around 27% fat. The difference was in the glycemic index, that those that followed the low glycemic index diet followed the low GI carbohydrates. So what they found after a year is that those who followed the low GI diet had better period regularity. They had better insulin sensitivity. Those with high insulin levels lost 2-fold reduction in body fat despite just a modest weight loss versus those that followed the conventional diet. Now, there was another study that was published in the Journal of the American Medical Association in 2007 by Evelyn and colleagues that did a similar study. They had a bigger sample size, but it wasn't done on women with PCOS, but what they found were that people who had the high insulin levels at the start of the study, like this group, lost more weight following the low GI diet. So it could be for individuals with high insulin that they may do better following a low GI diet. So some helpful eating strategies I like to use with my patients in my practice is to reduce their intake of carbohydrate. Again, portion control is very important. Emphasizing the benefits of the low GI carbohydrates, the whole grains, the unprocessed grains. To avoid sugary and refined foods as much as possible, to help them recognize that on a food label, that what are the sugar words. Really to help them to spread carbohydrates evenly throughout the day. And to eat frequently, say every 3 to 5 hours, to help to maintain consistent blood sugar levels to prevent any hypoglycemia. And again, to increase their protein, especially lean protein, with all their meals and snacks to add to satiety. Emphasizing the omega-3 fats, limiting saturated fats, and avoiding trans fats. As far as fertility, so again, PCOS is the most common cause of ovulatory infertility, so a lot of women with PCOS may be seeking nutrition counseling for infertility. The largest study we have so far was done with the Nurses' Health Study. It involved over 18,000 nurses, and the research was conducted by Walter Willett and Dr. Shabro, and they published their findings in a book called The Fertility Diet. But what they found was that the nurses who had the most ovulatory infertility had the highest amount of protein, and those especially that had the highest intake of animal protein had a 39% more ovulatory infertility than those with the lowest. Those who consumed the most plant-based proteins had the lowest amount of infertility. The exceptions were for eggs, dairy, and fish, which were actually found to increase fertility. So some really interesting studies. We definitely need more research, but it shows some light on the role of diet in fertility. These are some supplements with insulin sensitizing properties. Cinnamon, this popular spice, is believed to increase the phosphorylation of insulin receptors, and this can lead to improved insulin function and improved insulin sensitivity. There was a meta-analysis involving 6 randomized control trials that showed that cinnamon can cause significant decreases in hemoglobin A1C and fasting plasma glucose in type 2 diabetes. Inositol, 2 specific types of inositol, D-chiro-inositol and myo-inositol, are perhaps the most researched nutritional supplements for PCOS. These are relatives of the B vitamins that the body produces, but both of these have been shown to have favorable results in improving nearly all aspects of PCOS, including insulin sensitivity. It has a role in reproduction. It can improve androgens and metabolic aspects such as inflammation, dyslipidemia, and hypertension. One study compared myo-inositol to D-chiro-inositol and found that myo-inositol restored ovulation and improved oocyte quality better than D-chiro. So these are similar carbohydrates, but they do act differently in the body. And what they seem to do is they act as secondary messengers, and they relay signals from the insulin receptors on the cell membrane inside to the cell nucleus. And it's really believed that women with PCOS have a defect in that insulin signaling pathway from the cell wall to the cell nucleus, as well as perhaps an altered metabolism of inositol, and that might contribute to insulin resistance. So definitely something to consider for your patients. Another one would be N-acetylcysteine, or also known as NAC. NAC is both an antioxidant and an amino acid, and it's been shown to improve insulin sensitivity in PCOS. There was a prospective trial that had 100 women with PCOS either take metformin or take NAC for about 24 weeks, and the results were very comparable, that both treatments resulted in significant decreases in BMI, hirsutism, fasting insulin, testosterone, menstrual regularity improved. And NAC also led to significant decreases in cholesterol and LDL cholesterol levels. There's also been 2 randomized control trials involving NAC as far as its use with Clomid, and it was found that Clomid with NAC resulted in improved ovulation and improved pregnancy rates compared to a placebo. Magnesium supplementation may also be beneficial to women with PCOS due to its ability to reduce insulin and glucose. It has a role in improving blood pressure as well. One study found that the risk of PCOS for subjects with magnesium deficiency was 19 times greater than those who had normal magnesium concentrations. And then vitamin D, we're not totally sure, but vitamin D may play a role in insulin resistance. But the vitamin has definitely been shown to be involved in follicular egg maturation and development, so it may have a role in ovulation and fertility. Fish oil pretty much improves every aspect of PCOS, whether it's for improving triglyceride levels, fatty liver disease, can help improve ovulation as well as depression, and can overall decrease inflammation and the risk for cardiovascular disease in women with PCOS. And certainly we know that it's important for pregnancy. I did mention earlier the role of exercise. I'm just going to talk briefly about this study, which compared women with PCOS, had them either do a very low-calorie diet or exercise about 3 times a week. Using a stationary bike, and this was in previously sedentary women, and what they found was that those who exercised had better improvements in their menstrual cycle than those who did a restricted calorie diet, and the ones that exercised also had greater improvements in their waist circumference and insulin resistance despite only a small reduction in weight. So exercise has a definite impact on ovulation and can certainly improve those metabolic risk factors. Now, as health professionals, there's unique challenges that women with PCOS have that can affect our counseling efforts. And it could be that women with PCOS are yo-yo dieters, so they've struggled with their weight their whole lives, not even perhaps knowing that they have insulin resistance or having PCOS. They may have intense cravings for carbohydrates. Hypoglycemia is very common. It's associated with the high insulin levels. Again, the dermatological concerns and the higher prevalence of eating disorders, they have more anxiety and depression, which can affect their ability perhaps to follow an exercise or eating plan. And impaired levels of ghrelin and leptin have also been shown in PCOS, indicating that women with PCOS may have impaired appetite regulation. So the role of the healthcare professional in treating PCOS, it's important that we take an empathetic and supportive and encouraging approach to treating PCOS, that we need to provide education on PCOS and insulin resistance. This is so important. I find that, it's really hard for women to make changes unless they know the importance. And they really have to own their disorder, and that means that they really have to have that knowledge base. So we need to be sitting down with them, and if it's an adolescent, having her parents present and really going through, what we talked about with the direct effect of insulin and how it relates to all the symptoms and health risks that they experience. Certainly counsel them on a healthy diet and exercise, encouraging a healthy approach to eating and exercise rather than just focusing on weight loss. This has got to be, behaviors that they have to adapt for lifelong. It's not a short-term fix. And I find that a lot of women with PCOS, they may not lose that much weight according to the scale. Women with PCOS have more testosterone, so they tend to build muscle a lot easier. Muscle, we know, weighs more than fat. So it's not surprising sometimes for a woman to lose inches, but the number on the scale might not change much. So not just putting that focus on the scale, but really we should be focusing on more of a healthy approach to eating. To assess their symptom severity, so checking for eating disordered behaviors, and assess their medication and supplement compliance. Those supplements that I mentioned aren't going to work unless they're taken regularly. The medications, the insulin sensitizers need to be taken regularly. And for women with PCOS, it could be a challenge because they may be taking numerous dietary supplements and medications. So, compliance, checking for that is important. So we may be able to recognize PCOS in our patients. Some questions to ask a patient you suspect of PCOS. One of the screening questions is just tell me about your periods. Are they heavy, irregular? Do you get them at all? What types of foods do you crave? Screening for signs of hypoglycemia if you ever feel lightheaded or dizzy. This question, have you ever been told by your healthcare physician, or healthcare provider that you have any abnormal lab values? So I once saw an adolescent client who, when I asked her and her mother this question, she said yes, she had elevated testosterone and was put on birth control pills to regulate her periods, but was never diagnosed with PCOS. Can you tell me about any excessive body hair that you've dealt with? Do you have any dry, rough elbows, skin tags, or any dark patches, dirty looking patches on your body? These are all signs of the high insulin. And certainly if you do suspect they have PCOS, does anyone in the family have PCOS? So even just asking that first question, tell me what your periods are like, if we can be screening all our female clients with this question, especially of childbearing age, we can perhaps detect PCOS and then recommend further diagnostic testing. So some effective tools that you can use. Food records can be a great self-monitoring tool. Using mindful eating exercises, especially if someone has difficulty listening to their inner cues of hunger and satiety. Food models and food labels, as I mentioned. Again, the scale might not be that effective. Waist circumference measurements may be more effective. And I also find that lab results can be very motivating. So if a woman sees that, okay, she's taking 2 grams of fish oil, look at the difference in her triglycerides. Or, I switched to eating more whole grain unprocessed carbohydrates, that look at what your A1C looks like. So I actually have in my book, the PCOS workbook, a lab results tracking form where women can track their blood results each time they have them done. So some conclusions about PCOS, that it's a underdiagnosed and undertreated really epidemic, that with age there's a higher risk for type 2 diabetes, metabolic syndrome, and cardiovascular disease, and really prevention and early diagnosis are key. And treatment may involve a combination of insulin sensitizers, healthy eating, dietary supplements, and lifestyle changes, so it needs to be individualized. If you're interested in learning more about PCOS, I do have a book called The Dietitian's Guide to PCOS available on my website, PCOSnutrition.com. And then if you are a woman with PCOS, or if you ever run groups, support groups for women with PCOS, the PCOS workbook could be a great facilitator's guide or self-help book. And certainly my website has a blog and tips and more information about those supplements and other PCOS information. And I'm also on Twitter. My handle is at PCOS Nutrition, and Facebook. And some other great websites I would recommend, the Androgen Excess and PCOS Society. If you are a professional that does treat a lot of PCOS, you may want to consider joining this group. And PCOS Challenge is another fabulous resource with radio interviews from professionals in the field. So we're going to open up to questions. Denise, you got some questions for me?
Yes, Angela. And as we're organizing those questions, I just wanted to make an announcement regarding evaluations and CE certificates. Everyone who has completed the webinar will be sent an email within 1 to 2 business days with a link to the evaluation. After you complete the evaluation form, the CE certificate will be emailed separately, again within 1 to 2 business days. Again, as we're waiting for the questions, and I'm afraid there might be too many here for you, Angela, I also wanted to take just a minute to announce our second annual COPE conference, which will be held here at Villanova University. It will start off with a pre-conference on Sharpen Your Social Media Skills with James Fellows, and on March 16th we will hold a one-day conference interdisciplinary on weight management tools to engage and sustain behavior changes, and please look at our website for more details. So time for questions and answers. I'm going to start off with, Angela, what advice can you give for treating thin women with PCOS?
That is a really good question. Can you hear me, Denise?
Yes.
Okay, I want to make sure I was still on the mic. One of the things that was brought up at that NIH workshop was that we really don't have a lot of randomized controlled trials on thin women with PCOS. And in fact, there has been no randomized controlled trials as far as exercise in lean women with PCOS. Even though they don't need to lose weight, there still could be benefits of modifying perhaps the glycemic load or the glycemic index in women with PCOS who are lean, because it's still believed that lean women with PCOS may still have an insulin problem, if you will, may have something going on with the insulin, maybe that messenger, that defect in the pathway from the cell membrane to the nucleus. So we still don't know a lot about lean women with PCOS, and that's just another phenotype that needs a lot more research, but I still think that dietary strategies can still have an impact on lean women.
Okay, thank you. It's a two-part question for you related to metformin. Should the metformin be extended release, or regular metformin?
It has been perhaps suggested that the regular metformin may be slightly more beneficial, maybe more effective, but that extended release seems to be better tolerated. So it just depends on the physician and any GI problems. But it's worth, suggesting it to the patient if she's having a hard time tolerating the regular metformin.
And also related to that, the question is, should the metformin be taken before, during, or after meals?
It's best taken with meals. It just is better tolerated if someone eats it, takes it with food. Okay.
We have another question for you related to sleep apnea and high testosterone. And the question is, my understanding was that high insulin levels were associated with sleep apnea. Would you please repeat what you said earlier about testosterone and the brain?
Sure. So testosterone affects the sleep receptors, or the central nervous system in the brain, and may contribute to sleep apnea in women with PCOS.
Okay. A second question for you, or third question for you, should women with PCOS follow a gluten-free diet?
That's a really good question. There's a lot of misinformation floating around the internet, and I think a lot of times what happens is women with PCOS are just so desperate for information, and there's so many women out there who have PCOS that have tried different things that work for them, and they promote it on the internet. Gluten-free diet can be very healthy for women with PCOS. It's certainly, if it's done properly, a gluten-free diet has a lot of unprocessed whole grains that can benefit women with PCOS. I don't necessarily think that it's a recommendation we should be recommending to all women, unless it's someone that has maybe some intolerances, or certainly who has a sensitivity or has celiac. But there has been no evidence-based information to suggest that that's what we should be recommending for women. And again, it could be a very healthy diet. I'm not saying it's for everybody.
Okay. And I just wanted to share with our listeners that we have over 400 listeners today for this webinar. So if we do not get to your question, I will pass them on to Angela and let her answer them directly for you. Another question that came in is, does the insulin resistance come first and cause the weight gain, which worsens the insulin resistance, or does weight gain cause the insulin resistance? And are these women lean when the insulin resistance begins? That's another two-part question.
These are other million-dollar questions, and I think it comes down to, what came first, the chicken or the egg? But I think the answer could be both. I mean, we're definitely seeing a genetic link with PCOS, that it's more prevalent among like mothers and daughters and sisters. But it could be both. It could be, from genetics, and you could be lean growing up and then hit puberty and then gain a lot of weight. And it could be from your environment, that, lack of activity and high intake of, high carbohydrate intake could contribute to insulin resistance.
And I know if you knew that answer, we'd have more solutions. Another question that came in is, do you feel that PCOS is on the rise because of obesity rates being high?
I think it is, and again, it comes down to the environment and lack of activity and extra portion sizes. I also think that there's been more awareness and more attention given to PCOS, certainly not enough. So that it is starting to get diagnosed a little bit more. And just as a side note, at the NIH workshop, it was actually put into the executive summary that should we, perhaps change the name of PCOS, because it's not just a reproductive, condition, just focusing on the ovaries. And if we change the name, that may lead to more recognition of the syndrome and more, media attention, perhaps.
Another question that came in, is acne limited to facial acne, or can it be elsewhere on their bodies, such as on their back?
No, the acne could be anywhere.
Okay. Another question, is it unsafe to take hormones with increased AST, ALT, and fatty liver? And
I don't know what you mean by hormones.
I'm assuming they mean maybe estrogen or birth control.
If you have elevated liver
but that's
enzymes.
it's not that, it wasn't that clear in here.
Yeah, I'm not sure I can answer that.
Okay. A request to find out more information about emotional issues and PCOS. Are there any good resources that you would suggest for that?
There's not a lot of research done. I do have in the Dietitian's Guide to PCOS a whole chapter on psychological aspects that discusses, all the mood disorders and the prevalence in PCOS.
Okay.
So I definitely recommend checking that out.
And maybe just one last question. Why isn't there a government-run national association for PCOS?
That's a really good question, and that was brought up at the NIH workshop, that we don't have a government-run PCOS organization like we do for, say, the National Diabetes Association or the American Diabetes Association, the American Cancer Society. And part of that could be, funding. The NIH, definitely recognizes PCOS, but we definitely need a government-run organization. And I think that will also put out some reliable and objective nutrition information and just, treatment information for women with PCOS, a site that they can go to and know that they can trust. So I think that would be great. And if they do establish a national organization, that might lead to increased funding for more randomized controlled trials in PCOS.
Yeah, it's really great that they held the workshop that you did attend, and we're certainly delighted to have you today as our featured speaker, and it was very informative. And I'm sure I'll be sending several questions to you as a follow-up as well. I would like to ask our listeners to also thank them for joining us today, and to please mark your calendar for our next webinar, which will be Thursday, February 28th from 12 to 1 p.m. Eastern Standard Time, and we are featuring Dr. Janet Bonbrill, who is an author, a nutritionist, and her topic will be on salt, shaking out fact from fiction, and you'll find out the latest information, which we all know that February is American Heart Month, so it's a very timely topic, and we hope that you can join us at that time. So thank you again, Angela, and have a great day, and we'll hopefully have many listeners next month.
Thank you.